So now next I'll be covering a very important topic, that's infection control in the ICU. So under infection control, these will be the main areas that I will be covering: designing, classification of infections, then standard precautions, isolation precautions, surveillance, bundle care, surveillance cultures, then antimicrobial stewardship. So coming to introduction and designing of ICU, the risk of transmission of pathogens and subsequent infection in healthcare facilities is significantly high. So pathogens may be transmitted from other patients via hospital personnel and or hospital environment. So the risk is variable and it depends on the patient's immune status, the local prevalence of various pathogens, infection control practices, and antimicrobial stewardship utilized during the hospitalization. So coming to the microbiology of infections in ICU, over the years there is a shift towards more resistant strains like MRSA, VRE, ASBL, CRE, CRAB, azole resistant Candida. So these pathogens play a major role in hospital-acquired infections and it is associated with increased morbidity and mortality. And it is associated with increased financial burden. So major factors contributing to this resistant strains developing are, the most important is antibiotic pressure. So selective pressure due to prolonged antibiotic exposure constituting an independent risk factor which determines colonization and infection status of MDR organisms in ICU. Example, antibiotic prophylaxis more than 48 hours is not associated with decreased risk of surgical site infections, but it actually increases the risk of colonization with multi-drug resistant organisms. Then severity of illness. Higher the severity, increased is the risk of multi-drug resistant organisms. Interruption of normal defense mechanisms like intubation and mechanical ventilation and malnutrition. Most clinically significant infections in ICU are VAP, CRBSA, and COTI. So the focus in ICU setting for infection control are hand hygiene, ICU isolation precautions, environmental cleaning, prevalence of device-related infections, active surveillance, and monitoring of infections in the ICU. So this will help in curbing the prevalence of MDROs, thereby decreasing infection rate. So coming to the classification of ICU infections, the infections in ICU are always crucial and need to be classified for any surveillance program. So the traditional approach was the cutoff of 48 hours has generally been accepted for differentiating community-acquired and hospital-acquired infections. But this concept has been challenged in the recent days because of this concept of carrier state. So condition of harboring an infective organism without manifesting symptoms of infection like HIV, TB, typhoid, Epstein-Barr virus. So hospital-acquired infections have been classified on the basis of carrier status of potential pathogenic microorganisms and diagnostic cultures. So you can classify them into three classes: primary endogenous infections, secondary endogenous infections, and exogenous infections. So here the microbial flora composition are both normal and abnormal pathogenic or potential pathogenic organisms like Streptococcus pneumonia. Whereas in secondary endogenous infections, it is aerobic MDR gram-positive cocci and gram-negative bacilli like MRSA and VRE. Whereas exogenous infections are mostly MDR nosocomial pathogens like Acinetobacter. So primary endogenous infections are usually the commonest with a frequency of 50 to 80%, whereas secondary endogenous infections contribute to 30% and exogenous infections contribute to 15%. So the mechanism of occurrence of primary endogenous infections is by imported uh, infections in the ICU during admission of the patient. Whereas secondary endogenous infections are colonization on skin, oropharynx, stomach, and intestine. Exogenous infections is hand of healthcare workers or contact with inanimate surface. So the time of occurrence is usually during the first week of ICU stay. Secondary endogenous infections is after 1 week of ICU, and exogenous infection is anytime during the patient's stay in the hospital. So coming to the designing of the ICU, appropriate designing of the ICUs lay the foundation for good infection control practices. So it includes the following requirements. You can classify it into three parts: engineering, environmental, and provision of isolation rooms. So ideal design for setting up an ICU unit of 6 to 12 beds is as follows. So it has to be at least 100 square feet. There should be additional space for ICU storage, nursing station, and doctor's room. Oxygen and vacuum outlets, there should be two per bed, and a compressed air outlet, it should be one per bed. Then environmental requirements, requirement for appropriate heating, ventilation, and air conditioning should be met. Minimal of 6 total air changes per room per hour, with 2 air changes per hour composed of outside air. So that should be the amount of air changes that should be there. And provision of isolation rooms. So you have negative pressure isolation room and positive pressure isolation room. So negative pressure isolation room is recommended for patients suspected to be infected with organisms which spread via airborne or droplet infections. So the direction of flow is from outside to inside. So these rooms have greater exhaust and supply more than 12 air exchanges per hour with a negative pressure of more less or of greater than or equal to minus 2.5 pascals. All right. Positive pressure isolation rooms are recommended for patients with highest risk of infection that are neutropenic and post-transplant. So the direction of flow is from inside to outside. So these rooms have greater exhaust and supply more than 12 air exchanges per hour with a negative pressure of more than or equal to plus 2.5 pascals. Here, the HEPA filter is a must. So HEPA filter is a nothing but high efficiency particulate filter. All right. So the recent updates that have come in the last 2 years, that is 2024 and 25. So with regard to the ICU room types, single rooms are preferred. It helps to reduce hospital-acquired infections. And these kind of single rooms should be in a format where it can be convertible for isolation rooms. Then air handling, that is heating, ventilation, and air conditioning. ICU patient rooms typically should have 6 total air changes per hour with 2 outside air changes per hour. The ICU room temperature should be between 21 to 24 degrees and the humidity should be 30 to 60% relative humidity. So infection control risk assessment, use facility level infection control risk assessment to decide airborne or isolation capacity designed for aerosol generating procedures. So water management, dedicated hand hygiene sinks, anti-splash placement, plumbing supports, Legionella monitoring and water safety plan is required. And surface and materials, non-porous, seamless, easy to clean finishes and should be avoided dust collecting ledges. So coming to the standard precautions, it should be followed for the care of all patients, even when the presence of infectious agents is not apparent or minimal. So the paramount of these is hand hygiene. So it is the single most measure to reduce transmission of microorganisms from one person to another. So refers to hand washing with soap or water or use of alcohol-based disinfection. So soap and water need to be done in cases with uh, Clostridium difficile infection or norovirus infections. So the 5 moments of hand hygiene must be remembered from an exam perspective. Before touching a patient, before clean or aseptic procedures, after body fluid exposure or risk, after touching the patient, after touching patient surroundings. So these are the 5 moments of hand hygiene. So the agents that can be used. So from all the reference I got, I have just compiled it so that it's helpful for last minute revision. So you have chlorhexidine that you have 70% ethanol or isopropyl alcohol with chlorhexidine. So the chlorhexidine percentage that is usually preferred is 2%, though 0.5 is also acceptable. So the main key ICU indications are following is insertion, surgical prep, or device side care. Then you have aqueous chlorhexidine gluconate solutions. So that comes in a concentration of 2 to 4% and it's mainly used as surgical hand scrub. Then you have povidone iodine, and you have two compositions of that. That is povidone iodine in alcohol and povidone iodine in aqueous form. Povidone alcohol in alcohol, povidone iodine in alcohol comes in a concentration between 5 to 10%, and it is indicated as a surgical site preparation when chlorhexidine is contraindicated. When chlorhexidine and alcoholic variant of povidone iodine is contraindicated, then you can go with povidone iodine in aqueous state. That is comes as 7.5 to 10%. So it can be used for skin preparation, wounds, and mucosa when when both alcohol-based povidone iodine and chlorhexidine gluconate is contraindicated. So these are the four solutions that are commonly used. So you have chlorhexidine and alcohol and aqueous solution. If chlorhexidine is contraindicated, you can go with alcohol-based povidone iodine solution. If both chlorhexidine and alcohol-based povidone iodine is contraindicated, then you can go ahead with aqueous-based povidone iodine solution. Next is personal protective equipment, that's PPE. So that is use of gloves should be worn in situations where exposure to blood and body secretions is possible. Also important part of contact isolation because it helps in reducing the likelihood of colonization with organisms from a patient who is colonized or infected with pathogenic organisms. Then masks. It must be used in settings where patients with respiratory secretions are there and patients undergoing sterile procedures. So gown, eye contact, and face shield should be used if the risk of contact or splash with blood or body fluids is anticipated. So coming to sharp safety, sharps and needles with safety device should be used. Used needles should not be recapped, bent, or used in any way. It has to be discarded in a leak-proof and puncture-proof container. Overfilling should be avoided. Once two-thirds of it are filled, they should be immediately discarded. So then coming to cleaning of the ICUs, ICUs should be cleaned thoroughly once a week by scrubbing with soap and water and daily with EPA registered detergents like ethyl isopropyl alcohol, quaternary ammonium germicide detergents like benzalkonium chloride and sodium hypochlorite. Please remember these three chemical agents which are used for disinfection of the ICU. So the recent recommendations that came from CDC in regard to hand hygiene was what I had discussed. Clean with soap and water or alcohol-based rub. Then PP use based on exposure risk. Injection and safety, medication safety. This is something that is new. Nowadays, the newer ICUs that are being developed are having a designated uh, area for handling drugs, that is loading drug infusions. Then minimizing exposure, early screening and management of potential infectious patients, sharp safety and handle equipments, what we had discussed, cleaning and disinfection, routine environment and equipment hygiene. Then safe injection practices. So sterile in technique for injections, single-use vials whenever possible. Waste and lineal handling, dispose of infectious waste, manage linens to avoid spread, and patient placement. Cohorting or private rooms has risk details. Apply transmission-based precautions whenever needed. So coming to the isolation precautions. So the three important precautions scenarios are contact precautions, droplet precautions, and airborne precautions. So for contact precautions, direct or indirect contact via hand services or equipments. So keeping them in a single room if possible, gloves and gown on entry, dedicated or disinfect equipments and daily environmental cleaning. So this is mainly done for MRSA, VRE, ESBL, CRE, Candida auris, large draining wounds or uncontrolled diarrhea. So combined with spore contact plus whenever seed of infection is there. That meaning to say you will have to go with hand hygiene practices very stringently, like washing with soap and water. Droplet infection, the rationale for it is the large respiratory droplets to the mucous membranes within a short range can spread. So here the key actions in ICU is mask on entry. So surgical mask itself is acceptable unless performing procedures. Then eye protection if splash risk is there, limit transport. So make sure if the patient needs to be transported, the patient wears a mask. So this is for influenza, respiratory syncytial virus, Neisseria meningitis, pertussis, Haemophilus, Mycoplasma, Group A Streptococcus, Rubella, Adenovirus, Parvovirus, and mumps. So here if you can see, other than Neisseria, pertussis, and Haemophilus, Mycoplasma, most of them are all viruses. Then airborne precautions. Small particles remain suspended and travel via air currents. So the patient needs to be placed in a airborne infection isolation room. N95 respirator is needed on entry with the doors closed, and transport limitation is needed. If at all they need to go, patient needs to wear a mask. And you need to use closed suction and minimize aerosol generating procedures like suction, open suctioning. So this is mainly in cases of pulmonary TB, measles, varicella, COVID-19, disseminated zoster. So coming to surveillance of monitoring of infections in the ICU. So surveillance is defined as a continuous systematic collection, analysis, interpretation, and dissemination of data. So about the occurrence of healthcare associated infections in a specific defined population. So the most important component of an effective infection control program is surveillance of monitoring of infections in the ICU. So the various infections that are monitored in the ICU are CORTI, CRBSA, VAP, and surgical site infections. So we have CORTI rate, VAP rate, CRBSA eclampsia rate, and surgical site infection rate. So the first three we had discussed under quality indicators. This one is for added information. So SSI rate is the number of SSIs after a given procedure divided by the total number of procedures performed into 100. So next is the bundle care. So you have the CLAPSI bundle. So the key elements are hand hygiene. Then you have maximal sterile barrier, that is cap, mask, gown, gloves, drape, skin antisepsis with more than 5% chlorhexidine gluconate in alcohol. Optimal site is to go with subclavian more than IJV, more than femoral, and daily review of the catheter site and prompt removal. Then you have Corti bundle, that is insert only for valid indication. Then aseptic insertion by trained staff, closed drainage system, drainage bag above the flow and below the level of the bladder, daily review and nurse-driven removal protocols, and do not treat asymptomatic bacteria. Then you have VAP or ventilator associated event bundles, that is head end of elevation 30 to 45 degrees, daily SAT SBT trial, SBTs, avoid circuit changes unless soiled, subglottic secretion drainage ETTs, early mobility and early enteral nutrition, oral care with toothbrushing, avoid routine chlorhexidine mouthwash. So the 2024 meta-analysis showed that toothbrushing is safe and helpful. Routine oral chlorhexidine in general ICU is not recommended because it has a neutral or harm signal. Then surgical site bundle, appropriate antimicrobial prophylaxis, age and dose timing, stop within 24 hours, skin prep with alcohol-based antibiotic, then maintain normothermia, perioperative glycemic control, and avoid shaving, clip if needed. So these are the surgical site infection bundles. Then coming to the other important aspect, it is about surveillance cultures. So surveillance cultures is defined as microbiological sampling from patients without signs of active infection at predetermined intervals. usually weekly, to detect colonization by multi-drug resistant organisms. So that is what surveillance cultures mean. So the purpose is to identify carriers early, guide empirical therapy, and strengthen infection control. So the rationale is ICU patients are at high antibiotic pressure, have high antibody pressure, they have invasive devices, and usually associated with prolonged stay. All these are really significant risk factors for increased multi-drug resistant organism colonization and infection risk. So colonization usually precedes infection. So the data helps in targeting empirical antibiotics, avoiding overuse, isolation or cohorting policies, and outbreak control. Example, MRSA or CRE. So the common sites and organisms. So usually from the nasal swab, organisms sought are MRSA. So the usefulness is to predict MRSA infection and guide decolonization, usually with mupirocin or fluoxetine. Then for rectal and perianal swab, it's used to assess VREs, CREs, or ESBLs. So the GI reservoir usually predicts bloodstream and urinary infections. Endotracheal aspirate is for assessment of MDR gram negatives. It has a high predictive value for possibility of VAP. Urine for MDR Enterobacteriaceae and Candida. It has a low yield, but it is useful for assessment in long-term catheterized patients. So wound or drain sites for any MDR organism, it is very important in the background of burns, transplant, or surgical ICUs. So the approach in ICU, baseline admission screen in high-risk ICUs like burns, transplant, or hematology, weekly surveillance cultures like rectal, nasal, and tracheal, trigger-based screening only during outbreaks or if the prevalence is more than 10 to 15%. Then integration with stewardship. Narrow empiric antibiotics if colonization is absent. Escalate empirical therapy if colonization with high-risk MDR is present. So the utility, the predictive value, the concordance between colonization and infection is moderate to high, better for gram negatives than gram positives. So infection control, it allows preemptive isolation and cohorting to prevent cross transmission. Then stewardship, it provides colonization antibiogram guiding empirical therapy and epidemiology. It tracks MDRO prevalence, helps in outbreak investigation. So the limitations of surveillance culture is usually colonization is not equal to infections. So it may lead to overtreatment. It is costly and labor intensive, and it has limited utility in low prevalence setting. So there's another problem. There is a lot of guideline variability with regard to surveillance cultures. So the IDSA key recommendation was no universal surveillance. Use targeted screening in outbreak or high MDRO burden ICUs. With regard to ESM, ECMID 2022, no routine screening for CRE, VRE, or MRSA can be done in high risk units. And with regard to CEDC in 2023, it is risk based, not universal. You need to integrate it with infection control strategies. So these are the current recommendations in relation to surveillance cultures. So practical ICU use cases where it is useful is in high endemicity ICUs like Asia, Southern Europe, and India. Outbreak settings, especially if outbreaks of MRSA, VRE, or CRE is there, immunocompromised or transplant ICUs. Where surveillance cultures are not useful are in low prevalence settings, less than 5%, or as a standalone diagnostic tool. So the evidence from trials, so selective digestive decontamination based on surveillance cultures decrease mortality in ICU infections but raise concerns of resistance. So the recent systematic reviews had a mixed benefit. The best use for surveillance cultures was in the high prevalence settings. So that is what you need to keep in mind. So surveillance cultures are most valuable in high risk or high prevalence ICUs as part of integrated infection control and stewardship programs, but routine use in all ICUs is not recommended. So other clinical infection control issues, so special considerations in immunocompromised patients. So protective environmental room. So you need to use positive pressure single room with HEPA filtration. Do not So with more than 12 air exchanges per hour. So this is what we had already discussed. So you need to monitor the pressure daily. So with regard to room contents and cleaning, important no flowers or potted plants in the protective environmental room, daily wet dusting, then HEPA equipped vacuums, and you need to avoid carpeting or upholsters furniture because the risk of dust, all that can have microorganisms which can be harmful to the patient. With regard to water safety, maintain a healthcare water management program, monitor temperature and disinfection, and respond to Legionella detections. With regard to diet and food safety, use safe food handling education. Routine neutropenic diets do not reduce infections. Reserve restrictive diets for specific indications for local policy. So these are the few things you need to keep in mind when you are managing immunocompromised patients. So the most important of them all is one, no flowers or potted plants. Healthcare water management program should be well implemented, and food handling should be very, very meticulously done. Then other clinical infection control issues is patients bathing with chlorhexidine in 2% impregnated wipes reduce the rate of hospital-acquired infections and the risk of colonization of the drug-resistant organisms. And single patient rooms are ideally preferred because it helps in separating infected patients from non-infected patients to prevent transmission. So then coming to the last part of the infection control, which is one among the most important, is antimicrobial stewardship. So antimicrobial stewardship refers to a systematic assessment of coordinated interventions that is designed to promote optimal use of antimicrobials by advocating selection of appropriate antimicrobial drug regimens. So adverse events of antimicrobial use is almost seen in one-third of patients. So it leads to emergence of antimicrobial resistance. So administration of an antibiotic course to a patient exposes approximately 10 to the power 12 bacteria in that patient to selective pressure, which may alter the intestinal microbiota for as long as a year, plus decrease the number of antibiotics available. It increases the risk of C. diff infection or colonization. So usually C. diff infection is considered as a surrogate of antimicrobial misuse, and it can lead to drug toxicity. So the goals of antimicrobial stewardship is to decrease antimicrobial resistance, decrease healthcare costs, and improve patient safety, patient outcomes, and patient safety. So these are the main goals of antimicrobial stewardship. So when all these are adequately implemented, it helps to reduce the length of hospital stay, reduce mortality, and reduce the need for mechanical ventilation. All these were possible when antibiotics were used appropriately. And also, there was a decrease in when there is decreased antibiotic use, there is a decrease in C. diff colonization, and there is no increased mortality and no readmissions to the ICU. So, antimicrobial stewardship program for ICU setting has two parts. One is optimization of the antimicrobial therapy, and the second one is avoidance of unnecessary antibiotic administration. So, coming to the first part, optimization of antimicrobial therapy. Step one, making a diagnosis. First, see if it is an infection. Then, rule out non-infectious mimics, rule out colonization or contaminants. Take appropriate specimen cultures to be able to make a eventual diagnosis and determine whether to start an antibiotic empirically or, if possible, wait till definitive diagnosis is made. So this is about the first part of it. Second, empirical antimicrobial therapy. The important considerations are the severity of illness. If the severity of illness is very high, then you go with broad spectrum antibiotic coverage. Likely pathogens and their anatomical source, with consideration of source control based on rapid diagnostic testing and gram stain as appropriate. The likelihood of drug resistance, like known colonization by resistant pathogens, recent antimicrobial use, exposure to healthcare facilities, and local resistance patterns. Then host factors, whether they're immunocompromised, needing wide spectrum of coverage, renal or liver dysfunction, where there can be increased risk of toxicities and allergies, which will preclude a list a certain particular class of antimicrobial agents. Then determining the appropriate dose and the route. Intravenous route is the standard in all critical ill patients in the initial phase of the disease. Then initiating antimicrobial therapy as early as possible and as promptly as possible. That is one among the most important determinants of outcome. And adequate dosing in PKPD considerations. So maximize tolerable dose and use of prolonged infusions whenever possible. Identify the presence of augmented renal clearance and identify increased volume of distribution like hypoalbuminemia, large volume crystalloid administration. So all these are the important considerations you need to keep in mind when you consider empirical antimicrobial therapy. Then tailoring antimicrobial therapy, that is the antimicrobial timeout. So in patients receiving empirical therapy, the regimen should be re-evaluated on a continuous basis as the clinical condition evolves and the microbial results and when the microbial results become available, usually within 2 to 3 days. So this is called the antimicrobial timeout. So at this time, the anti-microbiological results are reviewed and the antimicrobial therapy is adjusted from an empirical to a definitive antimicrobial therapy. Then fourth step is therapeutic drug monitoring. Now it is currently confined to vancomycin, aminoglycosides, and voriconazole. So its use has been associated with the reduced nephrotoxicity, reduced length of stay, and reduced mortality. Then coming to the second part of the stewardship program, avoidance of unnecessary antibiotic administration. So this concept is mainly about antimicrobial de-escalation. So it is a clinical approach to empirical antimicrobial therapy of serious infections that attempts to balance the need for an appropriate initial therapy with the need to limit unnecessary antimicrobial exposure to curtail the emergence of resistance. So avoidance of unnecessary antibiotic administration, it can be done by use of antimicrobial resistance prediction tools based on risk factors. Biomarker guidance of antimicrobial therapy with use of CRP or procalcitonin helps in guiding decisions regarding antimicrobial therapy. Use of rapid microbiologic diagnostics. So use of molecular platforms currently exist for rapid identification of pathogens and antibiotic susceptibility. So it includes MALDI-TOF, then multiplex PCRs and immunochromatography. So it aids in faster diagnosis and de-escalating of antibiotics within 24 hours itself. So this is in comparison to conventional microbiological procedures. Then we have a stewardship team. So we have a physician leader with ID training, should report activities and outcomes regularly to senior executives and hospital board, co-led with the pharmacist leader with ID training, then clinicians and head of departments, hospital epidemiologists who monitor, audit, analyze, and report facility-wide data, quality management staff to investigate medical quality and patient safety issues, then microbiology lab, antimyograms to provide empirical therapy is the main role, then IT staff to integrate stewardship protocols to the existing workflow, and nurses to ensure cultures are taken before starting antibiotics. So, like quality indicators, metrics for stewardship program also, we have various indices. So, measuring antibiotic use may be estimated by the days of therapy. So, the formula is the aggregated sum of days for which any amount of a specific antibiotic is given to a particular patient by a standardized denominator, usually 7 to 14 days. Then we have something called the daily defined dose. That is the aggregate total number of grams of antibiotic administered during a period of time divided by the standardized defined daily dose regimen designated by WHO. So these are the two indices that can be used to assess the antibiotic usage. Then you have process measures. So excessive days of therapy. that is unnecessary days of therapy based on acceptable targets and benchmarks, duration of treatment, proportion of facilities complying with facility-based guideline and treatment algorithms. Especially this is very, very important in ward-based management because many a times patients in the ward are given empirical antibiotics which may not be compliant with the hospital antibiogram. Then proportion of patients with revision of antibiotics based on microbiological data and proportion of patients converted to oral therapy. So all these can be assessed and audited. Then outcome measures. Hospital length of stay, 30-day mortality, unplanned hospital admission within 30 days, proportion of patients diagnosed with C. difficile infection attributed to antibiotic treatment, and proportion of patients with clinical failure, that is need to broaden treatment or recurrence of infection. So these are the outcome measures. So here you have 5 process measures and 5 outcome measures and 2 measures to assess antimicrobial usage. So just an overview revision of antimicrobial stewardship. So suspected infection in ICU patients, you obtain microbiological sample for culture and special stains, biomarker assessment like CRP or procalcitonin, and rapid diagnostic testing like PCR or MALDI-TOF or immunochromatography. Then prescribe empirical antibiotics, employing a combination of an agent targeting like MDRO based on local epidemiology and patient risk factors. Then monitor the clinical response to treatment. Then microbial identification of pathogens and antimicrobial susceptibility. That this need to be done at 48 to 72 hours, which is the antimicrobial timeout. If there is identification of a microbial agent and if there is significant improvement after 48 to 96 hours of treatment, and you can classify it as if there is no microbial identification with significant improvement after 48 to 96 hours of treatment. So if there is no microbiological identification and there is significant treatment after 2 to 4 days of treatment, then you consider discontinuing the antibiotic or limiting the course of therapy to seven days or within 7 days. Whereas if you have a significant improvement after 2 to 4 days of treatment and microbiological identification of a pathogen is present, then you de-escalate empirical antimicrobials based on the microbiology result and discontinue antibiotics after 7 to 10 days based on the site of infection and the pathogen present. Whereas if there is no clinical improvement in either of the situation, then review dosing of antibiotics to optimize drug levels, reculture for possible superinfections, consider non-infectious cause of fever and inflammation, and examine for abscess formation. So this is the generalized approach of going about infections in the ICU patients. So this is my last talk for this crash course. So all the best to all of you. Definitely, I'm sure that all of you would pass. Just be confident and give your hard work as much as possible. Thank you.